so probably there must be lots of traffic to enter now. Hi, Danielle, how are you? Abdulaziz, how are you?
Hello, Américo. Olá, Tiago. Yes, Narmin, we are starting in a few minutes. Hi, Varun.
Just 2 minutes that it's missing, okay? So, probably you can share already your presentation, put on the first slide. Hi, Massimo. How are you?
Can you see the first slide?
Yes, we are all seeing now.
Okay.
Okay, and it's growing.
A lot of people coming now.
Yeah.
Hi, Pedro Pena.
Hi, people from India. Thank you very much for your attendance.
I think some of these colleagues came from the Full Arch Club. So, hello, everybody. It's a pleasure.
Hi, everyone. 9 o'clock, so we are going to start. Thank you for everyone for coming. We are now in 120 people attending. Hope to go till 350, the number of registered people on this webinar, which I thank very much to for your attendance and for Bernardo could share with us his knowledge and his experience. So, Bernardo, without any further delay, I will pass it to you because what we really want to see is your presentation, okay?
Oh, thank you, Rui. Good night, everyone. Good night to you, Rui. Thank you for your invitations. We dentists, we are a strange kind of people, right? We could use this quarantine time to watch Netflix, to read, and to do some other things, and we prefer to be here talking about teeth at 9 o'clock in the night. And this is crazy. Thank you all for your attendance, and thank you all, Maurice Salama, for the invitation. This webinar will be present at Dental XP platform, and yes, it's an honor to share my 2 cents about this amazing field of dentistry. Not only the full arch, but the customized implants. So let's start with this. And if someone starts having troubles on the audio and on the video, just let me know on the chat, because I can read what you're saying. So, people from the ancient times until today, humans, we always try to preserve our teeth. We know from all the civilizations like China, Egypt, and even the American continent, people try to keep it. And people also started doing implants made out of stone, of metal, ivory, and also seashells. And we have seen a lot of cases like this one that you are seeing right now from Egypt. With these gold wires, they try to keep their periodontal compromised teeth in any way they could. We also have seen these wonderful artifacts. You can see these teeth over here made out of stone and also iron. This is rusty iron over here. I don't know if you can see my mouse. Can you see my mouse? No? Okay. Yeah, this one was rusty iron, and also from seashells. You can see here these two incisors made out of seashells. This was the beginning of implantology, of trying to replace teeth. And so the time went by, and in the 1700s, we all studied George Washington, the first president of the United States. He had several dentures because he was a denturist from a young age, and his dentures were made out of human teeth, sometimes slaves. And in the 1800s, people they were extracting teeth and immediately placing in fresh socket implants made out of gold and made out of platinum in order to try to replace teeth. So we have this in our minds as humans. We always want to keep our teeth the most time possible. And then for the full arch cases, people that lose the whole set of teeth, sometimes the dentures they could not fit because the bone atrophy was so big they could not keep the denture in place. So in the 40s, yes, in the 40s, this is very, very old technology. We start to see the first superiosteal implants. And this started with a Swedish doctor who placed this metal structure, you can see here on this X-ray, under the gum and above the bone. So because this was below the periosteum, we call this the superiosteal implants. This was the starting of this technology. This technology back then. Okay, you can hear me? Yes, it's just Varun that is not hearing. Okay. So. Okay. But there is Bruna is also saying.
Listening, please try to see your configuration because everyone else is listening very well. Okay.
Okay. So this technology back then is these superiosteal implants. They took 2 surgeries. Now I have a fly over here. And the first surgery was to make the bone impression. So they would do one surgery just to open the flap, do the bone impression, and then do another surgery where they would place the superiosteal implant, because this implant back then was made outside of patient's mouth, obviously, but in the stone model. They were bending the alloy, and so this was the way people were doing the superiosteal implants back there. This was a metal alloy, chromium cobalt alloy, and there were no fixations whatsoever. So there were no screws. It was just sit on top of the bone. And this type of implants, because of this way of fitting, have several complications. The biggest complication of the superiosteal implants in the 40s, in the 50s, and in the 60s were the mobility of the implant, because the implant was not fixed. This implant was just held back in the position by the soft tissue on top of it. So this led to bone exposures, necrosis, and several bone atrophies. Also to chronic maxillary sinusitis and oronasal fistula. And this was a big problem, mainly in the upper arch, because of the gravity. So the superiosteal implants on the upper jaw, they had a failure rate very, very high. In the lower jaw, the failure rate was not so high, but it was still very high. We are talking about 30, 40, 50% of them would fail in 5 years. So it was a technique that people had to start stopping to do it, because it was not good enough. Many of you are seeing right now the QR code, and you will see some QR codes during this presentation. If you point your phone to a QR code, it will open or a video or an article. So use your iPhone to get the content, the special content I prepared to you in this QR code. And then everything changed with Professor Brandmark, the father of implantology. Professor Brandmark, in 1952, he was studying the microcirculation of blood in the rabbit's leg. And what he did was he put a kind of an implant with an optic sensor inside, because he wanted to connect it to a microscope to study the microcirculation of the blood. And then after the study, what happened is he wanted to take out the implant, but he could not remove the implant. And then he started thinking, what is happening here? Why is this implant not coming out? And this was the start of the osteointegration as we know it today. So Professor Bernmark started an implant company. These implants back then were polished. And in 1965, the first patient was treated. And something very, very curious is the first patient treated with these modern implants, as we know today. It was actually a full arch case, and it was actually an Allen 4, because this patient he had no teeth from the time he was a kid, genetic problems. I don't know exactly what, but this is not very well documented in history. But he has severe genetic problems, and he had no teeth whatsoever. And so the first case with implants was actually a full arch case with 4 implants per arch. And it was done by Professor Brandmark in 1965. And then in 88 was the first zygomatic surgery, also from Professor Brandmark. And 10 years later, the zygoma implants start to be accessible to the dental community. And it started like this. 1 year later, in 1999, Madsen, another Swedish doctor, published this first article. You can get from the QR code. Very, very interesting article. One of the most important articles in full arch rehabilitation topic, because it described what would be the first Allen 4. You can see here this picture on the left. This was the schematic drawing by Professor Madsen about the position and what he was designing in his head, the concept of what would be the future Allen 4 technique. This was in 1999. And then in 2003, Paulo Malo published the first Allen 4 study with the word Allen 4 as we know it. And 2 years later, he published the upper jaw. So in 2003, it was first was the lower jaw. 2 years later was the upper jaw. I don't want to lose many time on this topic, but as you know, and as you, Rui, you should be feeling this in some part. This was involved in a lot of criticism, because we humans we tend to reject what we don't know and what we don't understand. And back then, imagine what was 20 years ago. Someone placed the implants completely angulated, completely tilted. It was really strange back then. And so this was involved in a lot of criticism. And I think we can do the parallel to what we are feeling today with this new concept of superiosteal implants, because it is very criticized also. Do you feel the same, Rui? Do you want to say something about this, or you don't feel, you think that generally this new age of superiosteal implants are not so criticized like these techniques were back then?
I am a clinician. I was a clinician,
Mm-hmm.
and I also
Yeah, it's
to see what is the papers about these new subvessel implants. You can see
I can't hear you, Rui.
You cannot hear me? Not seeing me. Sorry.
No.
Are
Okay.
you listening me?
Can you hear me?
Yes, I do. Can you hear me? No.
Can you hear me?
Yeah, that's
Okay,
because
okay.
you have your presentation and
So I
probably
don't
you're
hear you, Rui. I will continue. But we were talking about criticism, right? Everything that is new is very criticized. It's normal. It's a normal way of thinking, and I hope that this presentation will change some minds about this subject. So about the biomechanics of the Allen 4 technique, so we need to prove two things, right? That tilted implants work as well as straight implants, and that we don't need more than 4 implants. So these were the two things that we had to prove. And then the studies start to come out. This one from Zampelis in 2006, very important study about the biomechanics when applying a pressure on a cantilever in a straight case or a tilted case. And you can see on the graphic that the stress around the bone, around the implant, is practically the same. It's basically the same. If we are talking about straight or tilted implants, it's no difference in stress. With different angulations, same stress at the bone level. You can also get this article using this QR code. So the conclusion they took is tilted implants do not increase bone stress, and that it's better to tilt and avoid the cantilever than put straight and have a big cantilever. As we can see in this case like here, we tilted implants and we get almost zero cantilever. If I were to place a straight implant, I would get a big cantilever here on the upper jaw. The other option would be to do the sinus lift, but the sinus lift, I'll have to do the bone grafts using membranes, waiting times. So with tilting the implants, we don't need any of it, and we can go for immediate loading with no regeneration, no waiting times whatsoever. But we needed more studies, right? The lab studies are not enough. So when we go up in the pyramid of clinical evidence, we are searching for the meta-analysis. And the first one came out on 2012. This meta-analysis comparing tilted with straight implants. And what they found was the same success rate in the implants. So we are not losing more implants just because they are angulated, and the same marginal bone loss around angulated implants and straight implants. Then the second meta-analysis in 2015, this is very recent, they came exactly to the same conclusions, the same success rate, and the same marginal bone loss around tilted and straight implants, like we can see in this picture. So we were talking about the position of the implants and what happens physiologically. Now we have to talk about the number of implants. Why 4? Why not 5, not 6, not 3? So this was the second thing we needed to prove. And biomechanics speak for themselves, and we go back again to Professor Brandmark. Because in 1995, Professor Brandmark published a 10-year survival rate prosthesis on 4 and on 6 implants. So Brandmark started this in the 80s. So in 95, he published the 10-year study. Comparing straight and tilted implants, you can get the article, you get the QR code with your iPhone. And Professor Brandmark came to the conclusion that the survival rate for both the implants and the prosthesis was the same in both groups at the end at the 10-year observation period. And he also said something really powerful to say in the dental community. Professor Bernardo said that the present tendency of some doctors to install as many implants as possible should be seriously questioned. So this guy is saying, why are you placing so many implants when you don't need all of these holes in your patient's mouth? And this was in 95. So about the biomechanics, trying to understand what happens physiologically and biomechanically when we compare 4, 5, and 6 implants. One of the most important studies was by Doig in 2000, and he came to the conclusion that it's possible that comparing 6 or 4 implants has no real clinical relevance. Also, Nakonechi, you can also get this article, published a very complete study about the bending movements, the hinging movements in several parts of the prosthesis, and he came to the same conclusion as before, that the implants resulted in a lower stress in bone and prosthesis with 4 or 5 implants in the similar way. So he didn't find any difference using 4 or using 5 implants. So why use more? It's the question we have to put. And then Paulo Malo came last year with the 13 years follow-up in the maxilla and an impressive, show you, 18 years follow-up in the mandible. It's the biggest study we know so far in full arch rehabilitation. 18 years follow-up is a long time, and the impressive results Professor Malo got was these ones right here: 93% survival rate, 92% success rate, almost in 20 years. We can almost say that we adults, in 20 years, we will not get this success rate in our own teeth, right? So very, very high success rates in these periods of time. And so we have to come to the conclusion that these misconceptions are only misconceptions. So the earth is not flat, the vast science work, the men have been to the moon, the chemtrails are not a thing, climate change is real, the coronavirus is real, and also that Alon 4 works and works really, really well. And then the international community, in 2016, by the ITI, they published this paper where they were very categorical when they said that there is no increased risk for implant loss in the posterior tilted implants in the mandible and in the maxilla. You can get the article with the QR code. And they said that the treatment protocol with at least 2 anterior straight and 2 tilted implants in the premolar region can be considered a valid option as long as the doctor has appropriate education, experience, and skills. So, being said this, what would be our ideal full arch solution? What would we want to be like the characteristics of ideal full arch solution? We want it to be fast. We wanted no complicated regenerations. We want to go immediate loading, and we have to put also ourselves in our patient's skin, right? We want to go for immediate loading. We want a cleanable prosthesis. We want high success rates in our techniques, reasonable cost, and we want few complications. And there is any technique that get you fewer complications than using the patient's native bone. The patient's residual bone will always achieve this type of techniques. Will always achieve less complications if we compare to complicated regenerations. So using the native bone decreases the morbidity a lot, and this basically is the standard Allen 4 technique. You can see here the standard Allen 4 in the mandible and the standard Allen 4 in the maxilla. A bimaxillary case over here, and we can see tilting the implants, avoiding the sinus lift, avoiding the nerve, and going for immediate loading without complicated regenerations, no bone grafts, no membranes, and no waiting times. You can see here another case. I will mark the sinus. Can you see the sinus with the red marks? And we avoid the sinus completely. So no sinus lift, no complications, no regenerations, and immediate loading. I'm going to show you another case. I will mark the sinus, and we finish the case. Oops. And we finish the case. I think everybody can hear me. Someone is saying that there is no sound, but I think the majority have sound, right? Okay. So, okay, thank you. So next case, I'm going to show you here the same. You can see here in the upper jaw, the anterior wall of the sinus. We go really close to the wall of the sinus, but not going in. Another case here, really close to the anterior wall of the sinus, but not inside the sinus, and we avoid the sinus lift. We avoid the mental nerve in the lower arch. You can see here the mental foramen. Another case here, you can see the anterior wall of the sinus in the upper jaw, in the right side, in the left side. Another case here, you can see here the anterior wall of the sinus again. You can see where is the nose. And all the cases with immediate loading. Always using the native bone of the patient, no waiting times, no delayed regenerations. Another case. And another case. Always watching for the 4 mm safe distance from the mental nerve. Another case, you can see here the anterior wall of the sinus, both on the right, on the left, always going for immediate loading. Another case here, showing the 4 mm safe distance from the nerve. And here you can see the exposure of the mental nerve on your right. And here, the same, you can see on your left, it's the same case. The proper exposure of the nerve, so we have no troubles. We detect the nerve, we see what we are doing, and we avoid it completely. Or also in a case like this, and we do the exposure of the nerve, and we work safely in the 4 mm distance from the nerve. We can use these guides for help us both in the straight implants, because we have these laser guides. You can see the laser guides here, right? We can use these not only for the anterior implants, but also to calculate the tilting of the posterior implants. You can see here the occlusal view. So I'm going back, I'm going too fast. And also here on the lower jaw, you can see the reflection of the burr in the guide. This guide was developed by Professor Paulo Malo. It's described on the first article from 2003. Very helpful guide. And it works like this, the 30 degrees from corner to corner. And it works at 45 degrees from corner to the midway of the next rectangle. So one thing that I am asked a lot of times is, if I have enough bone, if I am going to tilt my implants, or I will put them in a straight position if I have a lot of bone. Well, 90% of the times I will tilt the implants in the same way. Why is this? Because as you can see in this OPG, I could go for straight implants over here, but the problem is that the bone density is not the same. If I go straight and place the implants in a more posterior position, or if I will tilt the implant and I'm going to reach with the tip of the implant this area here next to the nose. Because we know, we can see this diagram over here. This was done by Dr. Francisco Teixeira Barbosa. It's our colleague. It's a Portuguese dentist working in Spain. Very respected colleague in the field of digital dentistry and periodontology, and the founder of PerioSpot. And he made this diagram, and we can see very, very clearly that the best area in the mandible is this green area between the mental foramen. It's the area with good bone density, and in the upper jaw, the best bone density is this anterior area of the maxilla, and is exactly in this area that we are going to place the tip of our implants. So, answering the question, yes, most of the times, even if I have enough bone, I will still tilt the implants, because I can guarantee that I have primary stability to go for immediate loading, and that is really important. It's our goal. It's to go for immediate loading in every case we do, in every full arch case we are going to do. Even if for that we have to use the nose wall as an anchorage point. I'm going to show you here. I draw in red. You can see here the margins of the nose, and the implants are inside the cortical. We expose the nose on purpose, and we go inside of it on purpose to engage the cortical of the nose in a really soft cases. Someone is texting me. So I'm going to show you here some cases. In the upper jaw, you can see this case over here. I'm going to show you incision line with two releasing incisions between the 6th and the 7th tooth. Bone exposure, the placement of the guide, you can see here that this bone is very bloody. You see the blood coming out of the bone, of the medular bone, really, really, really soft bone. After the bone reduction, sometimes we lose all the cortical and the bone is too soft. We really have to tilt the implants and go all the way to the piriform process and to the nose to get the primary stability we need. And we place the multi-unit abutments, and we finish our case always with immediate loading. I'm going to show you a lower Allen form. You can see here the tooth, the teeth, and the placement of the implants and the multi-unit abutments. You can see here the filling of the sockets. This is 100% autogenous bone with no membranes over it. We just removed this bone was removed with the bone ranger, and then we fill all the sockets only with autogenous bone. We get high success doing this technique instead of going with the bone substitute and membranes and all that stuff. That's not cheap, and we have the best bone of all in our patient, which is his own bone. You can see here this BMAX case, the upper jaw, a little bit thin crest over here in the anterior part. We can also see here the nasopalatine canal. And after bone reduction and the placement of the 4 implants and the multi-unit abutments, after suturing, And now the lower jaw of the same patient. This patient wanted a cheap solution for the lower jaw, and so he wanted two locator and a removable overdenture. But in this type of cases, I'm going to show you how this was before. This type of case, I like to prepare the bone as if I'm going to do an Allen 4. Even if it's only for two simple locators, I always prepare the entire arch like I was going to do an Allen 4, because later they can change their mind and they can upgrade their solution. And it was exactly what happened to this patient. So we did two locators, and then 2 months later he came back and he wanted a fixed solution like he was getting in the upper jaw. So I just did these two semi flaps and placed the two posterior implants, and then I changed the two locator abutments, and he got immediate loading also in this solution in the lower jaw, both on the first two locators and then in this second intervention. And this was the final case. I am going to show you here another BMAX Allen 4. You can see here how these teeth were, very opalous teeth. This is the upper jaw, a thin crest, and the placement of the 4 implants and the 4 multi-unit abutments. Here, the posterior ones, the one on the right, was a little thinner. This could be a palatal approach. At the end, it was not, but this could be a palatal approach if it was a little bit more thin. We will talk about this in a few minutes. And here it's the lower jaw and the lower Allen 4 surgery and immediate loading on both arches. So another upper jaw Allen 4. This was a really thin crest. You can see here on your right side. And after the bone reduction, we lose cortical. It's true. We lose the best bone, which is the cortical bone, the hard bone. But the bone is now wider enough to place the implants. And we also need to think of the transition zone. So the transition zone, now it's not visible. And we place our implants. And we go always for immediate loading. Allen 4 and sinus lift. This is this is a little bit strange. It doesn't appear every day, but we can see here. Can you see the first quadrant? This big mucocilius inside of the right sinus. You can see it's a little bit more opaque than the one on the other side. So in this case, this was the frontal picture. We did the two things in the same surgery, and I'm going to explain you why. So he had the retention cyst on the first quadrant. We removed the cyst. We did the sinus lift. We sutured the hole, and we went for the sinus lift. Everything filled with bone. And we went for the Allen 4 and for immediate loading in the same procedure. This is the lower jaw, the fourth quadrant. We went for a partial Allen 4. You can see here, I'm going to show you back. You can see here, distal to this implant, all the bone that is distal to this distal implant this is very, very thin bone. So for me to place an implant in this a little bit posterior, I will have to do a lateral horizontal bone graft. So we also avoid it in the lower jaw. And this was here we can see how thin this was in our left. And so this was before. And this was the case after the surgery. You can see the sinus lift here on the first quadrant, and we can see the partial Allen-4, just half Allen-4 on the fourth quadrant. And I also wanted to show you, we are going to push a little bit more to see in what extent can we go with the Allen-4 technique before going to the other solutions. So this case, this typical Kelly, right? You see this big defect, the anterior defect caused by the anterior teeth on the lower jaw. I'm going to show you here. Just look how big this defect was. This is the right side. This is the left side. You can see here this type of defect, and we had to correct all of this. This was the mandible, and this is after the bone reduction. After the surgery, after the BMAX Allen-4, and we finish like this. So this was very important in this case, because now the gingiva, the excess of tissue, not only soft tissue, but also hard tissue on the posterior area is not seen in the big smile. So now we can rehabilitate our patient, because the bone is flat, the gingiva is flat, the prosthesis is now flat. It's very easy to clean now. And we pass from situations like this, we go to situations like this without showing that enormous amount of tissue in the posterior area. So, how, to what extent can we still go for the Allen-4, and before having to go to more complex procedures and still go always with immediate loading? I'm going to show you here a case I also shared in our Full Arch Club Facebook group. You can see this the occlusal picture of this patient. You can see the open flap over here. Alex is asking me what instrument to make the bone reduction. I love to use acrylic burr. Okay, you can see in the Full Arch Club YouTube channel a bone reduction video. Just write Full Arch Club on the YouTube, and you can see the bone reduction video. You can see it all. So you can see this occlusal picture. This case was a thin maxilla, and in this case we can still go with the Allen-4 technique with the palatal approach. You can see that the implant is very exposed on the palatal side, but not on the buccal side. We always need to have bone on the buccal side. That's what protects the implant. And in the buccal side, we leave these threads exposed. We are not filling. We are not going to graft these threads. The keratinized soft tissue of the palate is very thick, and it will be able to close and to create a junction between the implant and the polished color of the multi-unit abutment with the soft tissue. So in this case, the grafting is not recommended. You can see here the detail of the two anterior implants. And you can see here the OPG and OPG after the placement. And the 4.5 years follow-up of this case. You can see that the keratinized tissue is not only sealing the palatal side, but we also have a lot of keratinized tissue on the buccal side, which is crucial for long-term stability. Not only the Allen-4 technique, but this particular technique, the palatal approach technique, we need to have really good tissue surrounding our implants. I'm going to show you here another case. We are almost finishing the extreme of the Allen form. You can see the anterior wall of the sinus on the first quadrant, right? And also in the second quadrant. I'm going to go back again. I'm going to mark it. Okay. So in this case, we went with a little deviation of the technique because we could not go to place the implant next to the second quadrant, the anterior wall of the sinus in the second quadrant. So in this case, we went to the pterygoid bone, the pterygoid process of the sphenoid bone, and we went also for immediate loading in this case. You can see here the occlusal picture. And we are going further and further and further, pushing to the limit, and 3 years follow-up of this case. I'm going to show you here a little bit more extreme palatal approach combined with the transnasal approach with pterygoid implants and an implant in the vomer bone. You can see here, this was the first OPG. Just look at these teeth on the first quadrant with the big infection in the root. This was the case when I meet the patient. So the tooth 17 was taken out by a colleague, and it was filled with some bone substitute. I don't know what it was. And you can see here the renderization of the CBCT. Extremely thin ridge. You can see here these 3 slices on your left correspond to these 3 slices, this blue one, the yellow, and the red one. I'm going to go to the next one. You can see how thin this was, these cross-sectional slices over here. You can see here. It's not, the bone in this case was thin, but it was also very concave, right? So the palatal approach in this case would not work. I'm going to show you again. Look at these 3 slices. Again. You can see the right side, the pterygo complex, the tuber-pterygo-palatine complex. And you can see here on the left side also the tuber-palatine pterygoid bone over here complex. So in this type of cases, we really have to search for the bone. It's like a mission. It's trying to read the CBCT and search for every little piece of bone that we can have, so we can avoid more complex procedures. I'm going to show you here. This was a video, so I think we can skip the video because it's not working over here. But you can see how this was. So in the first surgery, this was what we did in the first surgery. This second implant was lost, was the only lost implant. It was the implant that was placed in the socket filled with bone substitutes. So the implant was very loose. I didn't load the implant. I knew I was going to lose that implant, but now I had a big trouble. The big trouble is I need to find room to place anything between the pterygo and the front one, right? Look at this CBCT. The right and left pterygoids. This is a little bit of anatomy. And here the implant placed in the vomer bone. You can see here. So now we have a big distance, right? Between this posterior implant on your left side, on the right side of the patient, and the midline implant in the nasopalatine canal. So we open this flap and we try to search for something to do a little bit of extreme palatal approach over here. And you can see this transnasal implant next to the one on the midline, and the palatal approach implant over here, right next to the place where the other implant was lost. So this is a detail of the crest. You can follow this ridge, really thin ridge, knife edge. But now we have two more implants between the pterygoid implant and the vomer implant. And now we are happy because this case went not for zygoma surgery, not for huge regenerations, and we still went for immediate loading. So, which is always our goal. And here you can see the pterygoid, the palatal approach, the transnasal implant, the vomer implant, the palatal approach, and the pterygoid implant on the other side. And this is everything finished. So now the part that we all want to know a little bit more about, and when there is nothing left. So is this the return of the superiosteal implants? Remember that when Alexandre Laventure is asking me, you don't use zygomatic implants. I will talk about this now. So we were talking previously about the first superiosteal implants in the 40s, in the 50s, in the 60s. These structures were made out of metal, a metal alloy that was just placed over the bone, right? The return of the superiosteal implants that Rui Coelho, which is the host of this webinar, and the founder of the Bone Easy company, you can go to their website at boneeasy.com and also on Facebook, Bone Easy. They are doing something completely different from the old superiosteal implants. This is so different, they should not even have the same name. Because the implants back then, I showed you how they were doing this type of implants. They were doing over a stone model. Nowadays, we are doing this by CAD/CAM. These implants nowadays are pure titanium 5th grade. And back then, it was a chromium cobalt alloy. This surface of the new implants, it's a titanium surface that is treated in the inner part. So the part of the implant that connects with the bone. I have here. This is a maxilla of a custom implant I did. I will show you this case later. So the part of the implant that is going to face the bone is a treated surface. The part of the implant that is facing the soft tissue is a polished surface. So it's nothing to do with the old school superiosteal implants. Also, these implants are not over the bone. These implants are placed in a small channels that we have to do in the bone. We have to prepare the bone to accept the implant. You will see it later what I am talking about. But this makes a huge difference on the success of this and diminishing the rate of exposure of the implant, because it's not over the implant, it's under the implant. It's different. These implants are also screw retained, and not only screw retained but also screw integrated, because these screws, you can see in this picture, the green screws, they are not osteosynthesis screws, they are titanium screws. So these screws have two functions, right? They hold the implant in place, and the screw itself is integrating. And also, we use a multi-unit connection, completely different from what had been done in the 50s and in the 60s, because most of the superior cell implants back then had a removable overdenture on top of that. And so these are the biggest difference in this new age of superior cell implant. It's a completely new concept, completely new way of designing, of producing, of placing, and also the results over time, the follow-up of these implants. It's obviously completely different, because you remember the biggest reason that the old school superior cell implants failed was because of the mobility of the implant, right? The implant was not stable. So imagine having something under your gingiva that is always moving in a block. Of course, it will not go okay for too many years. This situation now is completely different, and now I'm going to show you some cases of this, because until now we were talking about pushing the limits of the L14, going the standard L14, going the palatal approach L14, going for the pterygoid, going transnasal, going in the midline, in the vomer bone. But when any of this is possible, we want to avoid complex regenerations and also the zygomatic implants. I don't have anything against zygoma implants. I think they are great implants. It's one of the best resources for extreme cases, but we we prefer to avoid it, because the complications of the zygoma surgery are usually big complications. We are talking about the fracture of the zygoma. We are talking about extraoral fistula, orosinusal communication, chronic sinusitis. We can talk about blindness. There are a lot of cases of blindness described. So, in a way to go minimally invasive, we are now not going for the zygomatic approach, but we are going for the new age of periosteal implants, but now properly done. Completely different from the old times. You can see this here. Now I'm going to change this view, because this is a video and I want you to see this video. This is 2 and 6. 2 and 6. So, okay. Can you see this video? Não vejo nada. Tá. So we can see here, this is a video. Can you see it? Yeah, okay. Of the analysis of the CBCT of this patient, you can see the extreme resorption. We will start on the first quadrant. Just look here on your upper left, and you can see we have almost no bone in any place. You can see now the second quadrant, no bone whatsoever. So this is the typical case that we would go for the quad zygoma, right? I'm going to go back to. No, it's okay. It's no problem. Here we can see also. Can you see these two? Can you see now? Mm-hmm. Yeah. Okay, you can see this. This first slice is at the premolar area, And the second slice is at the lateral incisive area. And I'm going to show you here what Bonizi, what Rui Coelho did to help this patient, the design that Rui Coelho made. Just look at this beautiful implant going to be screwed in the cortical bone, the only cortical bone that we had available in this case. So I want you to pay close attention, please, to the chambers, to the channels we had to cut on the bone so that the connectors of the implants stay below bone level. Can you see now? The anterior area.
Yes, we are seeing.
We can see very, very easy that the implant is not on the top of the bone, but instead infrabony. So these green screws are the titanium screws. The zygoma, these two on each zygoma are a little bit longer than the other ones. And you can see here very close to the nasopalatine canal. Now without any teeth, and you can see the design, the cuts in the bone. It's easy for you to see? Yeah.
Yes, we are seeing very well. Can you hear me?
Yep, perfectly, Rui.
Okay, we are seeing it all very well.
This beautiful design that you made. Gorgeous implant. So this was our implant. The screws, titanium screws, not osteosynthesis screws, and the four blue multi-unit connections that came with the implant. So the implant comes exactly like this, and Bonizi will send you also for specific multi-unit abutments to fit on this implant. Here you can see the upper arch. Can you see the picture? Yeah. And now the placement of the implant. You can see the preparations of the bone and these connectors. You see my mouse also? No. And the connectors, infrabony, and the titanium screws, these gold titanium screws over here, just under the nasal fossa. And we can see here, I don't think you have seen this picture, Rui. Maybe at the LV Congress, right?
Yeah, I saw it in LV,
yeah.
Yeah.
Of the case. And here the final OPG, what it looks like. The patient didn't have enough money to go for the same on the lower. They're still trying to convince her. And now I'm going to show you another case with no remaining bone, but with the sinus communication. You can see here this case, really atrophic, more atrophic than the previous one. And we can see here on the second quadrant the communication with the left sinus. I'm going to show you here the CBCT. It's starting on the first quadrant. You can see there is absolutely nothing, just 1 millimeter of bone around the sinus. And we are going now for this area, for the communication area, where we have a hole and absolutely nothing, which is this case that I have right here, this model. I don't know if you can see me. It's the one I have right now with me. We also send this case to Bonizi, and this was the planning of the implant, of the superior implant. You can see here again two screws, two titanium screws in each zygoma, and 3 screws here in the palate going through the vomer bone, because it's hard bone to get good primary stability, and 2 more here in the area of the anterior nasal spine. And also the other ones on the right and left side of the nose, which is a typical area of really hard bone. This is a really, really beautiful custom implant. You can see now the details of these 5 inferior screws going to the vomer bone right now. Can you see it? And the zygoma screws. Or should we say implants, right?
Yeah.
It's screw and an implant at the same time. So, and the implant itself, beautiful piece. This was then printed and sent to us. This came also with the model. This is the aspect of it. So the part that we are seeing is the part of the implant that will be facing the soft tissue, is polished. The other part is treated, and this is the aspect of it. So we can see in gold the mini screws or the mini implants. We have to decide, Rui, if we call these implants or if we call these screws. I am always confused.
Yeah.
And the vision, you can see here the two arms going for the zygoma bone, and the double fixation on the zygoma bone. If one fails, we always have the second one. And with the lower Allen 4, we always go for immediate loading on these custom implants as well. And I'm going to show you a custom implant in a case with the simultaneous extractions. These cases were cases with no extractions. Now we can see here this third case. You can see here 2 roots on the front area. You can see these teeth with infections. So this was the frontal picture and the occlusal picture. You can see here on the right side, this lesion on the mucosa is caused by the removable prosthesis of years and years and years and years, traumatizing the mucosa. And we can see here the STL of our patient. How was the mouth? You can see this was all hair, big sinus pneumatization on both sides. Also, the nasal fossa was very pneumatized. So every bone that we are seeing is just a really thin shell of bone. And here we can see this beautiful implant. This is my oldest case, Rui. This was done in a clinic that I'm not working anymore. And unfortunately, this patient, she was Brazilian, and now she moved to Brazil, so we lost track of the case. The case was going really, really, really good. I'd like to have follow-up pictures, but I think it will be very difficult for now because she moved to Brazil, and I don't know even what city. So it's a pity, but I'm sure it will be okay. And this was the implant. You can see the channels prepared on the bone in pink. And this is how the implant is coming on the implant kit. Came with spare mini screws or mini implants if we lose one or if we need to remove it and substitute for another one. This is the part of the implant that is contacting the bone. You can see the surface is treated, is not polished like the other one, and also the guide that help us to do the bone preparations that we were talking before. So the implant, these connectors of the implant that connect to the arms of the implant stay below the bone level, so there is no muscular activity over them. And this is the picture of the placement on the implant. It's very easy to see here on the left side of the picture. Here the channel going on this to the right zygoma, and also the channel in the bone going to the left zygoma, and also the bone preparations for the two anterior implants. We can see here a detail of the first quadrant zygoma of the first quadrant, the two screws or two mini implants, and a detail of the second quadrant. And a occlusal view, this bone, I was telling you, it was so thin. We can see here below the palate, this gray area. Can you see here? Below the full arch word, this gray area, it was so thin, it was even gray, even in the palate. And this is the OPG of the case finished. So we did the extractions, bone correction, the custom implant placement, and the immediate loading, as we do in all of these cases. And this is the end of my presentation. Stay home. Thank you very much for being here in a weekday. These are my contacts. You can send me an email. You can find me on Facebook and also on LinkedIn. And this is our Facebook group, Full Arch Club. You can join us there. Just point your cell phone.
Just a minute. Let me put here for everyone can put it on the cell phone. Okay, Bernardo, thank you. Nice presentation. Very nice pictures, very nice cases also. I already knew that you are going to do a presentation like this. I know it for a long time, but for the people that didn't know him, he's a very good practitioner, and we all love it very much, your presentation. Saying to everyone that this presentation, it is record. In a few minutes, I will share with everyone the link for YouTube as soon as I can upload it to YouTube, so you can see it, this presentation again if you miss something, okay?
Thank you, Rui. Thank you so much for this invitation. And for me, it's never too much to say that it's a pleasure to speak about so clever technology that was that this is so different from the previous periosteal implants. I don't even think they should share the same name. So this is a wonderful technology. For anyone that is here with us today, please try it or go with someone who is used to do this type of cases, because it will be a complete game changer. Because we are talking here about mouth rehabilitation, teeth rehabilitation, but what you are doing with Bonizi, it's a complete another level. Many people may not know, but you are doing a really maxillofacial bone printing, or printing I've seen a fractured orbita and a fractured zygoma, and you are printing orbita and zygoma. You are printing the skull. You are printing a lot of structures. It's completely incredible what you are doing right now, and for me it's a big honor to be able to share a little bit of what is possible to do today with this type of technology. So thank you all. It was a big pleasure. Stay home, stay safe, and see you at the Full Arch Club.
Okay, thank you. And
Thank
to
you.
everyone else, see you also tomorrow. The presentation tomorrow will be in Spanish, so lots of people will be out, but anyhow, the Spanish people can come and enjoy Vladimir talking, okay? Thank you again, Bernardo, and
Thank
see
you.
you. Okay, bye.
Bye.